Welcome to our public talk on lower back pain and the spine this evening. We have two of our speakers today. We have Katie Gill, who is one of our lead sports medicine physician, physiotherapist, and Matt Cosgrave, who is a sports medicine physician. Now, some of you have probably joined these talks before, and some of you may be new, so welcome. If you don't know us, we're a sports medicine and orthopedic hospital about 10 minutes from Dublin Airport. We have 83 beds and 18 day beds and 7 theatres. We do all MSK, anything to do with the bones, the joints, so joint replacements to hands, shoulders, knees, hips and spines. And we have a state-of-the-art physiotherapy building and sports medicine department as well. So I'm Fiona Roach, I'm the business development manager here. So we're going to start the talks with Katie, and then Katie's going to join us live for a live Q&A, and then Matt's talk will follow that, and then Matt will join us live as well. So you can see the tab there, ask a question. So if you have any questions, just type them in. Now, we'll endeavour to answer most of the questions tonight. We might not get through all of them, but some of the questions are coming through already, but you may get your answers when you're listening to the talks. We can always come back. There's another tab there for making an appointment. And you can email us as well. There'll be addressed there if you have any other queries or you do want to make an appointment. These talks are on our website. So even if you don't catch this tonight or you want to recommend it to somebody else, then you can go on the website and watch it at a later time. And there are other talks then on other parts of the body as well. So we're going to start tonight with the first talk, and I'm going to introduce now Katie Gill. Thank you.
Evening, everyone, and firstly, thank you so much for giving up your time this evening to listen to this presentation about management of low back pain. My name is Katie. I'm one of the senior physiotherapists and the lumbar spine lead here in sports medicine department in the sports surgery clinic, and I'm also doing a part-time PhD alongside my clinical work in the area of low back pain and exercise. So firstly, a little bit about my background. I qualified as a physio from UCD in 2011. I worked in a lovely private practice for a number of years in Dublin before moving to London to undertake my master's in advanced practice MSK. I worked in the NHS for a couple of years in a mixture of acute and persistent or acute and chronic services. And I moved back in 2018 to start my current role in the sports surgery clinic. About the hospital itself, so you can see the top picture there is the main hospital, and that's where all the orthopedic surgeons work out of and where all the operations take place. The picture below is where I work, so that building is just around the corner, but still part of the hospital. And in that building is this team. So we have really a good mix of services here. So we've got physios, strength and conditioning coaches, nursing admin, sports medicine consultants. So you'll hear from Dr. Matthew Cosgrave later this evening. And I'm one of 8 physios and SNCs who are doing research alongside our clinical practice. The reason for that is really so we can get our patients better quicker and to contribute to the body of knowledge and really provide excellence in our clinical care. The aims of the presentation this evening, so what will we go through? So first of all, we're going to look at the background of low back pain and the categories. We're going to look at guidelines for treatment and looking at management and advice from a physio perspective. I know Matt is going to come at this from a medical perspective in the evening as well. We're going to look at some myth busting and look at some signpostings for some resources, and there'll be time for questions at the end. And just as a note that the presentation shouldn't be used for individual advice for your own for your specific kind of queries or back pain. We're kind of talking generally around low back pain this evening. So if you have any specific questions or concerns, I'd advise you to seek the advice of your own physio or healthcare professional. So firstly, what to expect from a physio consult. I'm sure some of you listening might be frequent flyers into physio and know what it's all about. Others might be listening this evening thinking, I've no idea what to expect when I have back pain and go to physio. So the first thing, and we'll expand on why getting a good history is important. But really we need to have a good conversation at the beginning and have a talk about about how long the back pain's been going on for and the history of it, the things that make it worse and make it better, and having a really thorough conversation first. Then there'll be a physio, there'll be a physical exam We'll look at how the back moves, how your hip moves, and take some strength measures. And at the end of the session, there's you should be some time for questions and going through some advice in the treatment section. So physio sessions are usually divided into three. So the history, the exam, and then the treatment. And I wanted to share this with you. So what is evidence-based or evidence-informed treatment? And as healthcare professionals, physios are obliged to work within evidence-based or evidence-informed treatment. And it just means that we have to really offer and be up to date with all the evidence and research that's coming in through our field. And if you're going to see a physio, that you should make sure that they are CORI registered, that you should be, I'll give you a link for where you can look up the register yourself, and just that if your physio is CORI registered, they're keeping up with evidence and standards. So first thing is back pain can be really scary, but it doesn't need to be. And I'm hoping that this presentation will help maybe alleviate some of those fears. And I find with my patients themselves that often the fears is not knowing what this pain means and what this pain is all about. It's just as charity physiotherapists, physios are trained to deal with what we would term as red flags, and that means something that is serious and something that isn't appropriate for physio. And the first thing that we're doing with all of our patients is making sure that they're appropriate for physio and they don't need to be sent on. So, we're doing that anyway. But what I would say, as you can see in the bubble, is if there's something that's specifically worrying you, do bring it up in your consult and say, look, I'm very worried about my back in terms of, is there a fracture there? Is there something wrong? Whatever it might be that's worrying you. So do bring it up, and if you haven't been explicitly asked. Now, we're going to keep coming back to this notion of a fingerprint, and because back pain can be very straightforward to treat, it can also be complex, as some of you might know. And think about your back pain as like your fingerprint. It's only yours, and it's very specific to you. And also thinking about that there's a person attached to that back pain. You're not just your back pain either. So we'll develop on this idea later on in the presentation, but remembering that your treatment needs to be tailored, obviously with the evidence base there, but needs to be tailored to you and what your specific needs are. So looking at the background of low back pain, the picture at the top is from a paper published in The Lancet. So The Lancet is a very well-respected journal. And in 2018, they did a huge series of papers, and they basically just highlighted how common and how prevalent low back pain is. So it's the leading cause of disability globally. At any one point in time, there's about 550 million people experiencing it at any one time, which is huge. And that most people will experience it during their lifetime at some point. I think it's because it's so common and because most people will experience it. I really think that hopefully talks like this and getting the right information out there, and that people know, back pain isn't necessarily something to be frightened of. It's absolutely unpleasant, but very treatable, and people should know what to do and not to do around their back pain. The biggest thing to take on this side is that if you're just playing a numbers game, most cases of back pain will settle within 6 weeks. So somewhere between 80 and 90% will settle within 6 weeks. And that's if you really do nothing, if you're not seeing your GP or physio or having any treatment. And I think that's a really empowering statistic, because remember, your back there is working away behind the scenes to settle down that pain. I often say to my patients, your back is like its own hospital. Your back is trying to sort that pain out. And another thing to remember is that serious causes of back pain are extremely rare. So it's less than 1% of patients have something that is serious or would require ongoing management or ongoing investigations and things, or that it's a serious underlying cause. And so it is very, very rare. But why do so many people feel there's something wrong? So I'll ask all of my patients if they're worried about their back. And I think loads of people feel that certain things seriously wrong because it's seriously painful. Like, the back pain really can be so sore. At the very best case scenario, you're uncomfortable and you can't do the things that you want to do. Worst case scenario, it can really be very, very painful. So naturally, I think if your back is really sore, it'd be natural to think, well, God, there must be something seriously wrong. And I hope that that can reassure you that the pain and damage isn't the same thing, and that you can be very, very sore but absolutely safe. So now looking at the categories of low back pain. So how do we categorize this? So really into two categories. The first is specific, so specific back pain. This makes up roughly between 5 to 10% of cases, depending on the research that you read. And specific means I can point to something and I know that's absolutely the cause of my back. It might be an infection. So say you've had surgery and there's an infection in the back, that's a specific cause, or you've had a fracture in your back, that's a specific cause. We know exactly what's causing it. Everywhere else is in what's called non-specific. So kind of 80 to 90% of people are in that category, and it's kind of a unsatisfactory, it's very broad, and I'm going to go into the reasons why it's so broad, but most people are in that non-specific low back pain. The other way we categorize is by timeline. So acute back pain being in the first 6 weeks. Persistent back pain is categorized from 6 or 12 weeks onwards. So why are so many people in that specific low back pain case, and why can't we tell exactly what's causing the low back pain in the majority of cases? And part of the reason is because of the anatomy of the lower back. If you imagine, say, my finger here, and localize my anatomy around my finger. But if you look at the picture on the left, so the yellow bits are the spinal nerves, and in between them are joints. They're all like the two joints might be a centimetre apart, and even on the right, a centimetre apart on the left. And there's a lot of anatomy within the same area, and all of those things have a nerve supply. So your skin, your muscles, your ligaments, even their nerves have a nerve supply, your discs have a nerve supply, and they're all very close together. So if you're lifting, carrying, moving, bending forward, you're going to be moving all of them. So it's very hard to say, well, look, absolutely one or the other. And if you look at the picture on the right, in terms of your lower back anatomy, it is very complex. There's a lot of muscles covering that area. So we used to think we were able to diagnose exactly the cause of it every time. And it's just the anatomy is too complicated to let us do that. And I know some of you will be thinking, what about this? And the answer to that is it depends. And Matthew's going to speak about Matthew's going to speak about this a little bit later, and that some of you will be told, well, I've bulging discs, I was told I've problems with my discs, and the discs have a nerve supply, so they can be very painful. And what I would say is that some discs can have degenerative changes, which is like getting arthritis of our knees, arthritis of our hips, or graying hair and wrinkles. It's part of our aging process and doesn't necessarily cause any pain. And think about how your body adapts to that. If it's slow change, slow over time, your body doesn't see that as a problem. But if you say had somebody who had, a sudden injury, so they fell down the stairs and there was, too much pressure, too much force, and there's a sudden change, then that disc can be painful. So the answer about the disc is it depends. Sometimes it is and sometimes it isn't. But what I would like to share with you, if you're still not believing me that disc can be this source of pain, is that this table, there was a huge study done by 10 years ago, and they did an MRI scan on 3,000 people, so a huge amount of people from the age of 20 up to 80. And these are all in people who didn't have back pain. So even if we're looking at disc bulge, so 30% of people in their 20s have a disc bulge on MRI that have no pain. And looking at and from looking across, so 60% for 50 years over. So it's a huge amount. And these people don't have symptoms. So it's absolutely possible to have changes on the MRI and for them not to be painful. So in red there at the bottom is the MRI findings. They need to fit in with your history and with your clinical pattern. So it needs to fit in with with your exam and your subjective, and I think getting some advice from your physio or healthcare practitioner around that is really important, and having them interpreted in the correct way. And I spend a lot of time with people who are just given reports and understandably have a long list of things that come up on MRI, and a lot of it is like grey hair and wrinkles. It's part of how the body ages, and not something to be worried about. So on to treatment, and Matthew's going to speak about a few of the specific things we can do. I'm going to focus on more of the advice and exercise. So again, like we spoke about earlier on, we want to be evidence-based or evidence-informed practitioner, and there's you might have heard of NICE, so the National Institute for Health and Clinic and Care Excellence. They're a huge research body that provides guidelines for things like low back pain or obesity and smoking, and same for Cochrane. So the following guidelines have been approved by these two bodies. So they're divided into acute low back pain and persistent low back pain. So as a reminder, acute low back pain is what is from 0 to 6 weeks. And this table is taken from the paper I referenced earlier on, and I have the reference for you at the very end of this presentation. And what is the evidence? What should we be doing in the first 6 weeks? So first things, their advice is to remain active. Education, what can be included in that will be specific to each person, but it will be things like remaining active, and looking at kind of pacing yourself and managing the things that you need to do. So if you have an irritated back in the first 6 weeks, is it the time to do a personal best on your run, or do a big clear out, or swing the grandchildren around and throw them around? No, probably not. It's about staying pacing yourself and maybe keeping yourself moving without overdoing it. The interesting part here is exercise therapy has a limited use in selected patients. So from a physio point of view, I tell people just to do the movements, things that they enjoy, and try to give them some basic exercises if I feel they need them. But it's more trying to tell people that they're sore, that they're safe, and to try to get them back into things that they need to do. And you'll note there at the very bottom, so things like manual therapy, spinal manipulation, massage, hands-on work should be in conjunction with the education and remaining active. So it shouldn't be done by itself. If you're seeing a physio and they're doing some hands-on, that's absolutely fine, but it needs to come with the advice and education as well. So recap on that, do's and don'ts for low back pain. If you want to take a picture of this slide, I don't mind. So do keep moving. You could talk to a pharmacist about pain relief. You can use hot water bottles, gentle mobility exercises to encourage normal movement. Really important to stay in work where possible. Don't panic. And again, coming back, totally understandable. Back pain is very, very sore. But we want to try to get the body out of this fight or flight mode and back into kind of more relaxed state. And don't, the advice 20, 30 years ago was stay in bed. Try not to stay in bed, and try kind of be up and moving around, and sort of every 20 minutes, half an hour, if you're sitting, resting, even standing up, sitting down, walk to the kitchen and back, and trying to keep yourself moving. What I'd say to patients in this time is that they're sore, but they're safe. So if you've irritated your back in the first 6 weeks, you're putting your shoes on, absolutely fine. Moving around the place is absolutely fine. Now, can pain be a good thing? I'm sure everyone is thinking that there's no way pain can be a good thing, and that I'm clearly like Pinocchio there, that I'm telling lies, but I promise you I'm not. Especially in the acute phase, think about that your pain is trying to talk to you, to tell you to change your behaviour. So there's a group of people who have this genetic mutation that they're not able to feel pain, and that sounds wonderful, but their bodies don't tell them if they have an infection, if they've broken a bone, and their mortality rate is quite high. So we need our pain system to be working, and it's telling you that, you know what, you need to pay attention to me. It's trying to, we're not going to go to the gym today, we'll do a more gentle form of exercise. So it is important that our pain system is there, because it keeps us it keeps that warning system in place. So it is a good thing. Now, so persistent low back pain is when the pain is greater than 6 to 12 weeks time. And what I would say is that if you've had pain for that long, I would go have it reviewed either with your GP or with your physio, really because you've suffered for long enough, and that there's lots of treatments available, and don't put yourself through it to put up with it for any longer than that. Now, same paper as I referenced earlier on, the advice here or the evidence here is slightly different. So advice to remain active and education are still really, really important. However, exercise therapy now becomes the first line of treatment, so it's as important. And that in conjunction, the manual therapy and massage, so hands-on treatment is secondary. So exercise, advice, education are all the first things that need to be part of a physio program. And some hands-on work can be used, but it needs to be done in conjunction with the above. Now, so what are the challenges in treating persistent low back pain? And we're going to remember that this is like your fingerprint. So and pain has a context. So best example I can give for that is, imagine that you're having a really good day, and that you fall up the stairs at work, and it's really funny. You think, oh my gosh, look, I've landed on my knee and I've hurt myself. Imagine you're late for work, you got soaked going in from the car, you fall up the stairs, land on your knee, and everything is the worst. You're really, really sore. It's the same thing that happens, but the context is different. So our thoughts, our feelings, our beliefs can shape the way we shape our pain experience. And remember that if we have an irritated or a grumpy back, that back is attached to a person and their lived experience. So, and all of our lived experiences are obviously completely different. And I'll expand on this in a minute. So this is pulled from the paper I referenced earlier on, and it shows that different things can be at play in terms of feeding into low back pain. So things like genetic factors, biophysical factors. So there is very strong evidence that people with low back pain have some changes in their strength and coordination. Things like other comorbidities like anxiety or depression, social factors, things like stresses, and if there's difficulties at home, or potentially someone's going through a stressful time at work or a divorce perhaps, that those things, do they cause low back pain? Not necessarily, but think of it like a dimmer switch, that it can dial it up or dial it down, rather than like a light switch that turns it on and turns it off. And remember that our pain and why low back pain has been persistent and more complex to treat is because everybody is going to have a different interplay, or some people might have absolutely no stresses in life and none of that going on, and really all we need to focus on is the muscles and strengthening. Other people, the strengthening is not a big factor. We need to focus on pacing and management. So it really just depends. Another way of looking at that is here. It's a busy slide, but here's a list of evidence-based impairments in low back pain. So on one side, you've got things that are reduced muscle strength, reduced muscle endurance, increased fatty infiltrates. I'll show you a slide on that in a minute. It's basically where there's fat within a muscle rather than surrounding a muscle. Things like fear of lifting and fear of movement are also prevalent in this group from a research point of view, and also things like pain, quality of life, and poor quality of sleep. And this is why having a really thorough subjective or exam with your physiotherapist is important, because they need to figure out how much and where, if you see that Venn diagram, where in that Venn diagram do you fit? Are we looking at muscles? Are we looking at fear of lifting? Are we looking at pain? And just trying to tailor that appointment to you. So what does exercise do? If it's so important in low back pain, why is it recommended? First and foremost, there's a group called the American College of Sports Medicine, and Take Low Back Pain Away. These are the guidelines, and I'd love if you could just take a photo of this slide for reference. This is what we all should be doing anyway. As healthy adults, we need to be getting our 150 minutes of moderate intensity exercise a week, or 75 minutes of vigorous intensity of exercise. And building strength should be done on 2 days or 2 episodes per week. So it's something we should be doing anyway, which is really quite a high amount of exercise, really, just for it's not to be fit, it's to have our baseline level of health. So sometimes with patients with low back pain, they can miss out on the benefits of exercise generally because they're sore. So really trying to make sure everybody's meeting recommended guidelines. But in terms of low back pain, again, consider the first line of treatment. And why do we recommend? We're we encourage our patients to do some strength training or resistance training here in sports medicine for a number of reasons. So bottom left is a picture of a cross section of the back. So that's if you were chopping yourself through here. And the two dark circles at the very bottom are the back muscles. I'll show you a picture in a second that shows an increase of the fat through those muscles. So resistance training can improve the amount of fat within a muscle. Other reasons for promoting resistance training, it is very good for maintaining joint range of motion in our spine, in our hips, and all over the body. In particular, it is excellent for building bone strength, as well as building muscle strength. And the other thing in terms of strength that we need, like our lives require us to have a level of strength. So if you think pushing a shopping trolley, opening a heavy door, lifting grandchildren, or walking to work, all of those things require us to have a level of strength. So it's really being able to meet the demands of your day-to-day tasks, whether that be running, whether that be lifting, and whether that be walking around your house, whatever your tasks are, just holding the body upright requires a level of strength. The other side of resistance training is its impact on our mental health, and we want to make sure our back pain patients are getting all the benefits from exercise that they can. So this is the slide I referenced earlier on. So these are three different people. So on the left, you can, blurry image, I apologize, but you can see the difference between them, and that's the fat within a muscle. It's like, imagine if you had a steak and you've got fat through the steak. If a muscle isn't being used, it doesn't get replaced with muscle or with fluid, it gets replaced with fat. And it just means that muscle couldn't possibly be functioning as well as the muscles around it. So what we want it to keep is that our back nice and strong and to be functioning well as a unit. And resistance training can play a really important part if there is fatty infiltrates found on MRI, to reduce them and improve the capacity, improve how the spine can function. Now, some myth busting. So some of these things I know are possibly going to be a little bit controversial, and if they are, what I'd like you to think about is if you don't agree, I want you to think about where you got the information from, or how those beliefs came about, particularly around posture, and we'll come to that in a moment. So there's a research group that's international, and they published in a very well-respected journal, and I've included, which I'll go through some of these facts we've spoken about already. And again, looking at that, it can be scary. And the second one I want to look at is getting older is not a cause of low back pain. And sometimes I think it's very almost lazy to say, well, I'm getting older and that must be why my back is sore. And that's not necessarily the case. And then we spoke about that scans can really show the cause of back pain. Now, sometimes they can. There is a time and place for an MRI scan. And continuing this, back pain is not caused by poor posture. I'm sure lots of you are thinking, I'm not sure about this. What we try to say now is your best posture is posture, and that you're not doing anything for too long. So if you have to sit for work, every hour you're getting up and moving around again. If you're sitting forward like this, as you can see in the diagram, that's okay. Just keep moving. If you're sitting backwards, you just need to be at work. You need to be comfortable if you're sitting, and that low back pain isn't caused by poor posture. The only person I've ever seen that had the most incredible posture, she was up straight for hours, was a lady I was on a course with years ago, and she was 8-9 hours up straight, and I remember saying to her that she held herself so beautifully. She said, yeah, that's okay, but I've really sore back. And she was a ballerina. She was trained to have this posture. She was incredible. but again, she was sore, and it was one example that really stuck out to me, saying, well, you know, this, what we're all told is stand up straight, pull your shoulders back, bad posture. It's, I think, cut yourselves a little bit of slack. It's likely not caused by your bad posture. Now, so in terms of physio in the sports surgery clinic, our contact information is here. We take self-referrals. You're able to phone us and book in for an appointment. Or if you have any inquiries, you can just take a photo of the slide there. You can email us. And here are the resources. And if you take nothing away from this this presentation, I just love you to take a photo of this slide, or if you have any questions, I can share the resources with you. The first one is the NICE guidelines for low back pain, and they're the guidelines I keep referencing. Anybody who likes podcasts, the back pain podcast is excellent. It's for both clinicians and the problem with low back pain is because it's so common, there's lots of information out there, and a lot of it is inaccurate. And not and can be really cause some confusion. So if you're listening to podcasts, they're the ones I'd recommend. And Power Beyond Pain is also another excellent podcast. The 10 low back pain facts, the one I thought that might be controversial, there's a link to that there. It's in the BJSM paper. That's this next link. We touched on pain earlier on in this presentation, and there's a really lovely video on YouTube called Explain Pain in 5 Minutes, and that is wonderful to have a look at, and explains the nature of pain. Finally, anybody who has, I couldn't recommend the Tame the Beast website more highly. Persistent low back pain is hard. There's no crutch, there's no cast, you can't see it. And there's some really helpful resources, and lots of my patients find that helpful. Finally, the COI register, if you're seeing that, if you're seeing a physio, just make sure you're on that register. And then finally, we'll take some questions.
Katie, thanks for a great talk, and we've got questions coming in already. So we're going to start. There's two questions you're going to kind of cover. There's a Mark Biggers question and Maureen Condra. So we'll start with Mark's. Do you have any recommendations for exercise that a person can do to help relieve pain from spinal arthritis in all three parts of the spine? Now, Maureen's question there is about lumbar discs that are fused together, and is there any treatment? So you're going to kind of cover both of those.
Yeah, I think so. There'll be some, there's lots of great questions coming in, and we'll try to answer as many as we can. But starting with Mark's in terms of exercises, like we spoke about in the talk, looking at things that you enjoy. So and try to, sometimes people with spinal arthritis, they find that extremes of movement. So it might be do yoga, but maybe avoid an extreme back bend or extreme front bend if that doesn't feel right to you. So what I'd say in terms of guidelines and pain from spinal arthritis is that the odd nip or pinch with pain is okay. If an exercise feels like, you know, you really don't feel good afterwards, it's really making that pain worse, that one isn't for you. So examples of things with spinal arthritis, there's no limits. You could run, you can do yoga, you can swim, really looking at trying to meet those recommended guidelines that I spoke about earlier, try to get your enjoyment in, but there's no Bible or gold standard of the thing you absolutely have to do. And that links in with Maureen's question, which she spoke about having some fusion due to arthritis. So what that will mean if somebody has lots of arthritis down at the bottom of their spine, some of the movement around that region isn't going to be as good, which we'd expect. But what you want to try to do is maximize the movement that you do have, and maximize the areas above where the fusion is or where the arthritis is, and below. So it might be making sure you're getting good hip range of motion and making sure you get good lumbar and thoracic range of motion. So from a treatment, from an exercise point of view, mobility work, yoga will be nice, resistance training will be nice. Medical questions I'll leave for Matt, but it really, like our guidelines from earlier on, is trying to meet recommended guidelines, do something that you enjoy, and if something doesn't feel right or is painful, or if you want more specific advice, I think I would chat to your own physio or GP.
Lovely, thank you, Katie. Right, so a question here from Ray Foley. So he's saying thank you for your time, and he's been diagnosed with spondylolisthesis in the past year with grade 1 slippage of the vertebrae onto the L5-S1 nerve, which is causing severe back pain and groin weakness. He has been going to physio and a chiropractor with limited results.
Okay, so I think my I guess follow-up questions to Ray, and we're trying to maybe not to answer this more broadly because I haven't assessed them myself, but certainly it depends if you've been giving this a good go with physio and chiropractic treatment. If certainly if this has been going on for a while, I think hands-on work from a physio or a chiropractor probably, it sounds like it's not working. So I think a different approach. It might be worth there going back to the GP and looking for a second opinion. What all those terms mean for anybody who's not familiar with them is just that there's a little bit of movement of one of the vertebrae, which is putting pressure on a nerve. There are some injection options, and there are some other depending on how severe you're impacted on from a very specific exercise point of view. So certainly I think if it's not working with physio and chiropractor, my first question is what type of things are they doing with you? If it is more hands-on, I would put a pin in that, go back to the GP, look for an opinion and move from there.
Okay, lovely, thank you. Okay, question here from Deirdre to Katie. I was wondering how long it takes the muscle condition to deteriorate, and with inactivity, especially in the lumbar area.
Okay, that's a great question. So I wonder whether that came from seeing the cross section of the spine. So in the presentation earlier on, I showed pictures of where there was lots of fatty infiltrates. Now that level of infiltrate takes years. So that's not something that would happen over weeks or over months. So that level of infiltration when someone is very sedentary takes years. So in terms of deconditioning, so you can lose some muscle strength within 2 to 3 weeks, but you can get it back again really, really quickly. So I don't want people to worry unnecessarily that if they've been on holidays or if you've been, unwell for a period that, your muscle strength completely goes. It really, really doesn't. And what you want to try to do is just to get your muscles in good condition as best you can. So you'd notice the difference in, say, if you were in the gym and what you would lift, if that is a good level of muscle strength. So it might be, well, I lifted my grandchild before I went on my 6-week holiday. I've come back super, they feel a bit heavier. You might notice some impact in your function after a number of weeks. A very significant deterioration where there's a huge amount of fatty infiltrates takes years, but you can notice some lower grade changes within a couple of months. I hope that answers that.
Lovely, Katie, thanks so much for joining us tonight. So next we're going to have Matt Cosgrave, one of our sports medicine physicians. So and Matt will join us as well live for a Q&A. Thank you.
Hello everybody, good evening. I hope you're enjoying the evening so far. I'm delighted to be able to join you and have a discussion around the sports medicine doctor role in managing low back pain. My name is Dr. Matt Cosgrave, or Matthew. And by way of introduction, a little bit of my background is that I studied in Belfast in Queen's University. I trained originally as a GP, working through a variety of specialties in the NHS. And then I moved down to Dublin to pursue a career in sport and exercise medicine and did my specialty training in Dublin. Outside of working in the clinic here at Santry, I work with a number of sports teams, but over the last 3 or 4 years, I've had the pleasure of mainly working with the Irish women's national rugby team, and over the last couple of years with Connacht Rugby men's seniors team. So from a point of view of what I hope for you to get out of my talk today, is really to answer these 3 questions. Do I need to see a sports medicine physician? Do I need an MRI? And do I need an injection? Before we get into things, I'd just like to reassure you all that when we talk to patients, these are the 3 most common emotions that they present with in relation to low back pain. Worry over some sort of underlying disease process or pathology that maybe they're missing. Confusion over often why their pain isn't getting better or why their pain comes and goes unpredictably. Or apathy, which is really down to a lack of motivation around managing their pain, in that no matter what they seem to do, they're always suffering. Interestingly enough, these 3 same emotions are often what physicians, physiotherapists, general practitioners experience with low back pain, because it can be a tricky subject, but hopefully I'll try and uncover some of the hidden truths behind that today. Do I need a sports medicine physician? I don't think we help ourselves by calling ourselves sports medicine physicians. Really, this is a common misconception that the only people that we treat are people who do sport or athletes. Really, we are musculoskeletal physicians. So yes, we do look after teams, yes, we do look after athletes, but we really look after any active individual, which from a point of view of day to day, that's really the general public. And the vast majority of the patients that we see in clinic here are general public and are not high-flying athletes in any shape or form. About 80% of people at some stage in their life will experience low back pain. And interestingly, about 80% of these cases will improve on their own or with very little treatment within about 6 weeks. My role really comes into it whenever we have this huge chunk of 20% who are not improving over the 6 weeks to 3 month period, which can be a substantial number when you crunch when you break it all down. Really, what the sports medicine physician does is considers, do we need to order other investigations? Now, this may be a scan of some description, a CT, an MRI, or it may be some blood tests. Really, the main role for us is to confirm a diagnosis. Often, once we have the diagnosis, actually managing the problem can be quite straightforward. Sometimes when we're in the dark about the diagnosis, we try and we almost have a trial and error process, but if we can confirm a diagnosis, it's often fairly straightforward to get on a plan to recovery. Excluding severe pathology is a big part of this, and this falls into the worry side of things for patients. A big concern that patients often have is there some sort of underlying disease process such as cancer? And that is extremely rare when it comes to low back pain. But nonetheless, when back pain has been going on for a long time, it's always something that we have in the back of our mind, and it's always something that we make sure we exclude. We'll also review the treatment plan that the physiotherapist or the GP has already put in place, and we'll see, can we add to that? We rarely change things significantly, but we'll make small adjustments. And then finally, we think about treatment adjuncts. So rehab is a huge part of what we do here in the clinic, but there's always options for some additional help. And often for us, that falls in the way of injection therapy, which I'll discuss for you in a little bit further detail later. So do I need an MRI? The simple answer is no, not everybody needs an MRI. And the vast majority of patients who have low back pain don't require an MRI. This is a really great graphic that explains why we don't all need MRIs. These are findings on individuals who are asymptomatic. So people with no back pain have a variety of changes, and the percentage of patients who have changes increases with age. Just for one example, disc degeneration in this top area, which is often reported on scans and often causes concern for patients. Nearly 100% of patients in their 80s will have disc degeneration. But even more interesting, at the age of 30, 1 in every 2 patients will have some degree of disc degeneration on their scan, even if they're totally asymptomatic. So a scan is not always necessary. So when is a scan necessary? And this is what we use scans for. This is what the sports medicine physician is really looking for. If we go clockwise from the top left, this is a condition called sacroiliitis. This is an inflammatory process where you get some inflammation in the base of the lumbar spine, where the sacrum, which is a little triangular bone, fits into the pelvis. The reason we look for sacroiliitis is it doesn't normally respond to conventional treatment. Usually it's caused by some inflammatory process in the bloods, and therefore we often need to give medication to reduce that inflammation in the blood, which will then reduce the inflammation in the joint. This is not very common, but when it does present, it tends to be in the younger patient. If we move over to the right then, we have this condition called facet irritation. This is a lumbar spine from the side. The square blocks on the left are the vertebral bodies, and they sit on top of intervertebral discs. The vertebrae then communicate with each other in the back through something called a facet joint. Now, this facet joint, like any joint in the body, a knee, a hip, they can become irritated and inflamed. So when we look at MRI scans of backs for patients who are not improving, really we're often looking to see, are there any individual joints that are irritated or inflamed that could be contributing to symptoms? And therefore, is there a target for some injection therapy? In the bottom left, this is the view of a spine in cross section. So this is like I've taken you, lay you down, and then chopped you along, and I'm looking down the body. This pointy bit at the back is called a spinous process, and this is the area that we feel when we feel down the back. In patients, again, usually young patients who are very active and who do sports that involve a lot of bending of the back, so gymnastics, tennis, there is a risk of developing something called a pars fracture or a stress fracture. So in the younger patient especially, this is always something that we want to exclude. Finally, which you're probably most familiar with when it comes to low back pain, is this condition in the bottom right. This is called disc degeneration. The black circle in the center is the spinal cord. The yellow marks to either side are the nerve roots. When you get a disc bulge or a disc protrusion, what happens is the center of the disc, which is a jelly-like material, pushes out a little bit, and it causes the disc to bulge. The disc itself doesn't move, it just creates a little bit of a bulging on the outside edge. Now this bulge can do a few things. One is it can create irritation around the nerve, and the other is if it's bad enough, it can put some pressure on the nerve. And then if we think about treating this, often what we think about doing is delivering some sort of injection therapy, usually a steroid, in and around this area to reduce inflammation and irritation and to reduce any pressure that's on the nerve itself. So these are the four main reasons why we do MRI scans, but we know specifically what we're looking for. We're not doing the scan and hoping that it gives us the answer. We're doing the scan because we think that we already know the answer and we're trying to confirm or exclude that. Excuse me. So from a disc point of view, I just wanted to give you a little bit more detail. So from a disc bulge point of view, the reason this is important, this is a spine on the left from the side. This is a spine on the right from the front. These grey areas that are running down the side and then are coming out on either side on the image on the right, these are nerve roots. Your nerve roots supply your sensation and your power to different levels along your lower legs. So when you come into us with symptoms, what we do is we try to correlate whereabouts on the leg, front or back, your symptoms are, and then when we do your MRI scan, we try to look at the disc at that level to see if it's causing some pressure around the nerve root. In many cases, you will have disc bulging that doesn't relate to your symptoms. So you may have disc bulging at this L1, L2 level, but your symptoms may be coming from L5 or L4. For that reason, MRIs are not useful in that they can create confusion for patients and sometimes for physicians as well, because we see disc bulging, but it doesn't marry up with what's going on in the history. Finally, I want to make a quick note on something which Katie has probably already discussed, which is a degree of fatty infiltration in the low back. When we are less active, we see a change from the left-hand side where the muscles are nice and grey, kind of like a fillet steak, to on the far right-hand side when the muscles are not being used because other areas of the back are having to work harder, for example, the facet joints. Then the back becomes weaker and we see this fatty infiltration. If we see this on a scan, it's a very good indicator to us that you'll respond well to rehab. So in summary, from an MRI point of view, we're looking to exclude significant disease. We're trying to correlate what we see and what you tell us with what we find on the image or on the MRI scan. It's really not guesswork, and we're not asking for the MRI to give us the answer. Finally, then, we're looking essentially, is there an area for injection? So if we see a disc bulge or if we see a facet joint that's irritated, and it fits with where you're sore and where we examine you, then that's usually a good target for us to inject. The injection is only part of the treatment plan, however, which I'll discuss. And that brings us on nicely. Do I need the injection? Injections are not always straightforward, and often patients are a bit apprehensive about them. I break our injection treatments up into two major areas. One is for nerve root impingement. So if we have this disc pathology, or there are other causes of nerve root impingement, but if we have nerve root impingement, we've got two options. We've got a caudal epidural injection, or we've got a more sophisticated CT-guided nerve root injection. Again, we're correlating our MRI findings based on where your symptoms are, and we're deciding on what level do you need the injection. Sometimes it's not always clear exactly which level. Sometimes you might have a disc bulge at a couple of levels, and sometimes you might have symptoms that correlate with a couple of levels. When that's the case, we'll often do a caudal epidural injection. This injection is done right down at the base of the spine. We inject some steroid and it flows up along and around the nerve roots, and it bathes the nerve roots at those lower levels in steroid, and it reduces any inflammatory or irritant change around there. It's a little bit of a broad brush stroke, and we're hoping to tackle a number of different areas in one go. The CT-guided nerve root injection, however, is much more selective. We do that when we are very confident that the image that we see on MRI fits perfectly with the way the patient comes in. Now, this is not always the case, but when we have this sort of scenario, you get much more relief from a selective nerve root injection than by doing the broad brush stroke of what we describe as a caudal epidural injection. Technically, the caudal epidural is slightly easier than the CT-guided nerve root. We perform the caudal epidural injections in the clinic here as sports medicine physicians. We do this under ultrasound scan. The selective nerve roots, however, we have to refer to our radiology colleagues in the main hospital for this, because it's slightly more sophisticated, and we want to be exactly and precise about where we're placing that steroid. The next group of injections then is for the joints. I mentioned to you earlier about this condition, sacroiliitis, or inflammation around your sacrum. Again, normally the way that we treat this is with some medication to reduce inflammation in the bloods, but on occasion, if you just have it on one side, it can be because the joint is irritated without inflammation in the blood. In that case, a steroid injection over that area can be very helpful. Again, we do this in the clinic here, and we do it using an ultrasound scanner to guide where we place the needle. Finally then is the facet joint injection, the joint between the different levels of vertebrae. Same principle, like a knee joint, like a hip joint. If it gets inflamed, they often respond very well to corticosteroid. It's not the mainstay of treatment, it's an adjunct. So we try to improve your symptoms a little so that you can then progress on and do whatever rehab is necessary. So are injections necessary? Not always. But we use them when patients are not improving or deteriorating in some shape or form. We only do them if the symptoms that you're telling us or the findings that we have on examination match up with what we see on the MRI scan. If they don't match, there's something else going on, and it's rare that that's the case. Finally, we do them if your symptoms are stopping you from doing good rehab. If you're too sore to rehab, and we have a focus for injection, these can be extremely helpful in trying to get you some pain relief so that you can do the strength work that helps to take the pressure off the back, that helps to get you moving more naturally, get you feeling more comfortable, and then get you back to living a healthy and happy life. So how do you access us? Very straightforward. Self-referral, GP referral, or physio referral. And where? You can forward an email or a referral to sportsmedicine@sportssurgeryclinic.com, or you can give us a call on this number and you can have a discussion with one of the staff on the desk, and they'll give you more direction about how to get in contact with us. I hope you found that helpful. There's a lot of information in there. You don't need to take it all away. It's really just to give you a flavour of what we do here in the clinic and how our role as sports medicine physicians help to supplement the work that our very successful and very proficient strength and conditioning and physiotherapy and rehab teams do here in the clinic. Thank you very much.
Matt, thanks for a great talk. We're going to start with some of these questions now. So the first one is from Tanya. She's asking, what advice can you give for the L4-5 disc tear with lumbospondylosis other than pain management?
So I suppose to a degree it depends on what the symptoms are. If there are what we describe as radicular symptoms, so symptoms that are not in the low back, traveling down the leg, then we have the option for some injections. If we have a good idea where the pain is traveling to and it correlates well with the MRI findings, then we could do a selective nerve root block. If it's a little bit broader or a little bit more difficult to ascertain exactly where the pain is radiating to, or if there's a little bit of discrepancy between what we're seeing in the patient and what we're seeing on the scan, then something like a caudal epidural would be a good option. So that might give some symptom relief, and then we would always do some follow-up rehab work, and that would be along the lines of the stuff that Katie discussed. Yeah. Strengthening of the low back, strengthening of what we describe as the posterior chain, which is the bum muscles, the hamstrings, the calf, and just trying to get the patient to move more comfortably and confidently.
Lovely, thank you. So, question from Margaret here. Is Botox successful in managing muscular spasms caused primarily by spinal fractures?
So, Botox we would use in a very select group of patients. Usually patients who have some form of muscular spasm or contracture. So these tend to be limited to patients who have an underlying neurological condition like cerebral palsy, or somebody who has maybe a long-term contracture following a stroke. It's not something that we use in the clinic to treat back spasm. Botox has a very broad effect on the system, so we can't target it to any specific muscle, and for that reason we're very selective about the patient group that we use, and we don't use it for back spasm treatment.
Okay, lovely, thank you. Question from John. Can a protruding disc in the lumbar region be the cause of constant knee pain?
It certainly can. If the lumbar disc prolapse is pressing on the nerve root that supplies sensation over the knee, then yes, it can be the cause. And often that is a case of patients who we see who have maybe had a long-term knee complaint for a number of years. When we see them, we assess their knee, we scan their knee, we maybe don't find much, and we get a little bit more in depth into the history. We find that actually they have some underlying back condition or back complaint, and we scan their back and we'll find a disc or a nerve root compression that's actually the main source of their knee pain. So in short, yes, that can be the case. Yeah.
Anna's asking, how could she get sciatica pain to improve?
So it's a multifactorial approach, I suppose. Again, it comes back to what are the exact symptoms of the sciatica. What does the patient look like? What are the imaging findings? Do we have an option for injection therapy? If we do have an option for injection therapy, is it a selective nerve root injection, or is it a caudal epidural injection? And then following that, can we get the patient comfortable enough to start to do some rehabilitation? And quite often the sciatica pain will resolve on its own. If it's very refractive, then we do have oral medication options. We have injection options, and then we have some of the rehabilitation stuff that, again, Katie discussed, that is often the next step to get patients over the line and back to full fitness.
Okay, lovely, thank you. What treatment exercise do you recommend for multi-level lateral stenosis?
So multi-level lateral stenosis, again, is quite a complex but broad diagnosis. A lot of it really depends on what the symptoms are. So the mainstay is going to be getting the patient strong and getting the patient comfortable and confident moving again. If they have some specific pain target or pain level in, from that, when we describe multi-level spinal stenosis, we're wondering, is there an individual level in the spinal column that's causing one problem more than the other? If there is, we have an option for a selective nerve root block again. If the pain is coming from multiple levels and we've tried oral analgesia, we've given it time and it's not settling, then a caudal epidural might be an option to give a little bit of a broad cover of a number of nerve roots at a number of different levels.
Okay, thank you. Question from Petra. For 5 years, she's been suffering from severe chronic SI joint pain after twisting her back, badly misaligned pelvis, which she tried to correct with exercise for SI joint dysfunction. Steroid injection did not work. She's asking, do we do SI joint fusion at the clinic?
In SSC Sports Medicine, we don't do joint fusion. That would be a surgical procedure. It's not something that I can recall having referred a patient for. Normally, we are able to get enough relief of symptoms through injection therapy and rehabilitation. But by all means, if there are refractory cases, then we may refer them to a surgical colleague for an opinion. So that would be either an orthopedic surgeon or a neurosurgeon.
Lovely. Okay. How big a factor is ongoing strength and conditioning to prevent a disc bulge, L4 or 5, for long-term prevention?
So long-term prevention, I suppose the key here is trying to keep people moving as naturally and as comfortably as possible. Any strength work is going to reduce the risk of any recurrence of low back pain. Disc bulges will happen regardless of whether or not you do any kind of strengthening program or a preventative program. But if you're stronger and you have better functional movement patterns, then you're much less likely to get symptoms and long-term symptoms from something like a disc bulge. If I can take you back to the slide that I used in the earlier on in my presentation, there's a huge percentage of people out there who have disc bulges, and that's not the source of their pain. And quite often that's what we find in patients who come into the clinic. So it's not so much that the strengthening or rehab and exercise programs prevent disc bulge, but they prevent low back pain in general, and they're very, very good at doing that.
Okay, lovely, thank you. A patient's just asking here, he has a pacemaker which is not compatible with MRI. What other scans could be used?
Again, it depends on the diagnosis, or at least the question that you're asking. If you're asking for information in relation to a disc or a nerve root, then we would have a discussion with our radiology colleagues as to whether or not there is an option to work around to get the patient an MRI. There are some MRI centres available that can do MRI for patients with pacemakers. In terms of, if the question is not related to a disc or to a nerve root, and it's a bony finding that we're looking for, then a CT scan would be an option. And then thirdly, we have options for X-ray or bone scan, but they would be used much less frequently, and I suppose we get much more detail from our CT scans and our MRI scans. But really it all comes down to what's the question that we're asking. Is it a bone-related problem, or is it a disc and nerve-related problem?
Lovely, thank you. How long will pain relief last from injections, and how many could you have?
So it depends on what the injection is that you're using. Typically, we inject steroid with some local anesthetic. The local anesthetic is relatively short acting. You'll get a few hours of relief of symptoms from that, but it'll wear off over the course of the day. A steroid injection builds up over the first few days, and usually you get your most benefit at around about 7 to 14 days. And then we hope for around about 3 months on average. Some patients come to us for a steroid injection of a caudal epidural or a selective nerve root. They'll get one injection, they'll get enough pain relief to allow them to do some form of rehabilitation, and their pain will resolve fully, so they'll never need a repeat. Occasionally we'll have patients who come and get one injection, get a repeat injection 3 months later, and then follow that pathway where they go on to resolution. And then unfortunately there are some cases that are much more resistant to treatment and may need an injection on a kind of repeat 3 to 6 monthly basis. we would usually only inject about once every 3 months, so maximum usually about 4 a year. But we're always reassessing the situation and trying to ascertain, are we doing the injection for the right reason? Is it for the same reason? Have things changed? So there's a lot of thought that goes into the process rather than just booking out 3 monthly injections for the foreseeable future.
Yeah, lovely, thanks. Deirdre says that thanks for this really informative talk. Is there any downside to steroid injections?
Yeah, I mean, there are side effects to any procedure that we do. In general, anytime we use a needle to pierce the skin, there's a risk of creating infection. In the clinic here, we quote 1 in 25,000, and we use a lot of stringent infection control procedures to try and reduce that risk. But that's the biggest concern anytime we do an injection is introducing infection to the site. From steroid itself, a steroid, about 1 in 100 people can get something called a steroid flare, where their symptoms can get a little bit worse before they get better. Some patients can get pain at the time of injection, which can last for a few days after. Some patients don't get any relief whatsoever, and so they go through the process, they go through the anxiety of getting the injection, and they don't get any relief. But by and large, they are the main side effects. Steroid can also give you some minor side effects, such as facial flushing, which might last 24 to 48 hours. It can also disturb your sleep for 24 to 48 hours, and it can also have an impact on your blood sugars. So if you have diabetes, we always recommend that after a steroid injection, you keep an eye on your blood sugars for a few days.
Lovely, thank you. Just one more then. She had an X-ray which showed a fractured disc, had physio for that, but 10 months later she's still in a lot of pain. She goes for walks, but very painful when sitting. Any suggestions where she should go next?
It's difficult to, from the amount of information available there, it's difficult to signpost. I mean, if she feels that she's not getting much benefit, or she's hit almost a roadblock with a physiotherapist, then perhaps it's time to see a sports medicine physician. Again, another assessment, a second opinion. Have a look at what information is there to date, what investigations have been done, and then decide on whether any further investigations need to be done and what other treatment options are available to the patient.
Matt, thanks very much for talking tonight. So we now are going to conclude the evening. There will be more talks in the new year, so when we have those, we will advertise them. Also, you can watch this back through on the website, and all our other talks are on the website as well, or if you can also redirect somebody there as well. We will be sending out an evaluation for tonight as well. That will come out to you tomorrow. Thanks again for joining us, and we'll see you next time.